understand their own environment in their own country that are living here. We want people that own the system, and we want people that are expert in what I call SOAID, but basically it's the acronym for expert in supply chain, expert in operations, expert in accounting, expert in information system, and expert in data analytics. We want people to know these areas. Now, when I say supply chain, we know what supply chain is. We spoke about it. We speak about these issues, so we know what it is. But what is operation? It's the science of processes, and it's more than supply chain. For providing good healthcare, there is more than just supply chain. We need to define processes, how to treat people, Yesterday I had in one of the breaks a discussion with some people about how long are mothers waiting in the clinic. They are coming at 6 o'clock in the morning and they are leaving at the evening, and they are told that they have to come and pick the results of the test the day after, and that's difficult. They have to work, their time is valuable. So how we shorten this waiting time? How do we make life easier? And then some of you may be surprised, why do we want people to be expert in accounting, or not expert, but to have some understanding? We want to have a good view of the system. We want to have a good view of all the transactions in the system, money-wise, goods, movement of money. This will give us, in addition to the standard thing, yes, we will know inventory, we'll know the movement of goods. It can give us a very good tool to, for example, fight corruption, fight leakage of goods, find forged medicine. So there is value for doing it. Information system, again, I don't need to speak much about it. Everybody, I never heard anybody saying, oh, Professor Basok, we don't need information systems in our healthcare delivery system. What I do here is a debate of what is a good information system, how to design the system, what type of data to collect, what decision will it support, and things of this nature. And then I am introducing something that might be to some of you. I'm speaking about some expertise in data analytics. So what is the expertise in data analytics? Once we collect a lot of data, the question is, do we have the tools to deal with large sets of data? And deal with it. Where is the fraud? Where does it start? What happens? So I would like our expert, our managers to have some knowledge, some good knowledge in what is called data analytics. So what should be done? And remember, this is all, I'm looking for a system that will be able to be so efficient that we will be able to do more and provide better healthcare with a smaller investment. So we want to have trainers So it's not only about training, let's say, the managers. We want to have local trainers. We want the trainers to be from Nigeria. And we want them to train all the people in the health delivery system. Next page. What do we have now? We have hybrid systems. They are mainly using foreigners to train the local people, and they are doing a good job, but not the best job that can be done. And I believe that these programs are not sustainable because we don't develop the infrastructure of the country, let's speak about Nigeria, to train its own people. And I believe that training your own people is very important. So the question is, how do we create? It's easy to speak about it, and I think that many people, if not all, will agree, yes, it's a good idea to have good trainers that are local, but how do we do it? What do we want to achieve? Next page, please. And I believe that we want more innovative systems and people, and I mentioned it before, that understand the local environment and encourage ownership of the health delivery system. And when I'm speaking about innovative, that's a key issue, and yesterday it was mentioned many times. So when I'm speaking about innovation, it's what Ravi mentioned yesterday. It can be the eye hospital, it can be the way we are treating tuberculosis in India. And remember, in the tuberculosis example that Ravi gave, he mentioned that the cost of treating a patient is 10% what other foundations are paying. Here comes the example of doing more with less. We can cut 90% of the cost. And why can we cut that much money? So Ravi mentioned, it's the local people that are running this system. It's not the foreigners that are running. When the foreigners are running the system, it's not that they are doing a bad job, but they are expensive, while the local people are not that expensive. So you can cut the cost, you can reduce the cost, and do more. We need to be creative about it. Next page. So we want to create a group of local experts to deal with the new systems, to do more with less. How do we create, what do we expect of this new expert to know? So we want people that has a PhD or a master degree, that are really experts, that are really aware of the SOAID, and I mentioned things, the supply chain, the operation, the accounting, and so on. They are expert in this area. We want them to be local. We want them to understand the environment. We want them to feel, to be motivated. It's their country. They should be the owners of the system. And we want them to conduct research, to be able to conduct research. And being able to conduct research requires some expertise. They have to learn how do you conduct research. Why do we want them to conduct research? Because we are going to introduce changes, the world is changing, the future is different. We want to know what works, what doesn't work. We hope to collect a lot of data and then to analyze it. So up to here, you're saying, yeah, that sounds good, but how do we do it? let's go to the next page. So before I go to how we do it, I want these people, or I think it's a good idea that these people will be housed, their home will be academia or the health ministry in their country. They can be in academia in pharmacy department. They can be in business schools. They will also, in addition to teaching the manager of the health delivery system in short courses, a week, 2 weeks, they will also teach, that's my belief, they need to do it, pharmacy students, a course for credit. Why? Because pharmacists are managing the health system in most countries in Africa. And when I speak with pharmacists, and sometimes I go and I see what they are doing, and I'm saying, why are you doing it? And I'm thinking to myself, I don't say it loudly, this is ridiculous. But I ask them, and they're saying, Professor Basok, we don't know. We never learned it. What do you want of us? We are pharmacists. We are not managers. We never learned it. And I think that they are right. So we need to have courses. Now, you can say, that's a great idea, Professor Basok. It's not simple. And believe me, I know. I'm a chair of a department in academia. I know that if you are coming and saying to people in pharmacy, we need a new course, what do you think? Somebody that the time is limited. There is a limit number of courses that students can take. And basically we are going to some faculty and telling him, you know, your course is not that important. We will delete it from the program and we will add a new course in management. People are not going to be happy about it. People are going to fight. And in every country that I've been, and I did speak with pharmacy people in academia, this issue was raised. So, okay, it's difficult, but we need to do it. So you will see that many of the things that I'm saying today are not that easy to do, but I believe that they can be done. And here I want to just go back, and yesterday Ravi gave the 2 examples about the tuberculosis, about the eye, and people ask, can it be done? With some kind of, you know, maybe in India it can be done, but here it's not really practical. Let me tell you a little story. In one country, a physician, a very famous Swedish physician, and noticed that there are not enough doctors to perform cesarean operations. And what he did to solve this problem is thinking outside of the box, and he said, I'll train women, not necessarily nurses, to perform cesarean operation. It will take 2 years to train them, but they will be actually the surgeon that does the cesarean operation. And you know what? After 2 years, when these women were trained, their success rate in operation was higher than the best physician in the Western world. And when you speak about it, people are saying, yeah, what's the wonder? You train them for 2 years to do only one thing, cesarean operation. This is very similar to the cataract hospital, same idea. Do one thing, do it a lot, and do it fine. Now, is it possible that something like this will be done in Africa? Do you know in which country these women were trained? No. So it happened in Mozambique and Tanzania. In Mozambique it was very important because it was done during the war and there were no doctors. And this doctor trained them to do it. Why am I mentioning this example in addition to the 2 examples that we heard yesterday? Because I guess it was very difficult to do such a thing. Yes, I'm aware that it's not simple, that there is some certification process and some laws and you have to change things. But it can be done, and you are able to do more healthcare, see outcomes, with actually less. Because bringing doctors and training doctors is expensive. And here there is an example, again, that by thinking outside of the box, in Africa, you can do more with less. Is it easy? No, it's not easy. Okay, so we spoke about the doctors, this expert that will be housed maybe in pharmaceutical department, maybe in business schools. This is a detail that we can think about it later. They will teach 4-credit classes, they will teach in certificate programs, and they will teach short courses for practitioners. Next page, please. How many experts do we need? So now we are beginning to think and solving the problems with some data, and what I'm doing here is really something extremely simple. But in this country, in Nigeria, there are about 40,000 facilities, clinics, hospitals. 40,000 facilities, it means, suppose you have only one manager in each facility. You need to train 40,000 people. If you have an objective to train 40,000 people, all of them, that's a huge thing. You can say, Professor Basok, you are dreaming. 40,000, how would we train 40,000 people? And this is only Nigeria. Okay, so we need to train enough experts in Nigeria that will train 40,000 people. And when I spoke with people here yesterday, everybody told me, Professor Basok, we are not interested in long-term solutions. We are not interested to hear that in 50 years you have a solution for us. We are interested in short and mid-term solutions. How do we train 40,000 people? Okay. So suppose each expert can train 400 people per year. Why do I say 400 people per year? Because I expect these experts, once we have them, to teach 8 sessions a year of 2 weeks each. So 8 by 2 weeks, 16 weeks. So 16 weeks, in a year we have 52 weeks. That's feasible to teach 8 courses of 2 weeks each. And they have plenty of time to also do other things. And you know, we need 100 trainers to do it in a year. Can we get 100 trainers? And remember, we are speaking about people with a master, with a PhD. That's a lot of people. And we cannot say, okay, we'll train 2 people, because then it will take so long and we are not really interested to wait such a long time. But with 25 experts, and the math is correct, we can train 40,000 people in 4 years. Because why? Because 25 trainers multiplied by 4 years, it's 100. So 100 in 4 years, using 4 years, we can train all the people. But yet you can ask me, that's very nice. We don't have these 25 people in Nigeria. How do we get them? Next page. So here I'm suggesting to have a new initiative that best management schools in Europe, in Africa, in the United States, In Africa, there are not that many business schools, but there are some good business schools. They will invite students from Africa to join their program, and for a master program, a year and a half later, they will graduate. Some of them, not all of them, will come back to their country, and we will have this expert to train people and to work at the university. And this is part of what I suggested. These are local people. These are Nigerians that will teach Nigerian, that know the system, and they are expert and they are ready to teach. Okay, so you're saying, oh, Professor Basok, this is a nice idea, but I hear it all the time. Going to a foreign country to get a master or a PhD is expensive. We don't have the money. So here what I'm suggesting is forget about money. These people will go and they will get full tuition, they will get a stipend, a living stipend. They will have to pay very little, clearly within the ability of people to pay. So again, the people that doubt are saying, oh, that's very nice, but where will the money come from? And I'm saying here we want foreign and local institutions to donate the money. So I want you to notice that I'm not just saying foreign institution. I'm not just saying these American universities will give the money, or donors in the United States, or foundation in the United States and Europe will give the money. They will have to give the money. We will need to raise the money, but I want also African institutions and donors to participate here in this initiative to train local people. Let's go on next. Before I continue with the money issue, is it feasible? And I'll speak in detail about whether it's feasible or not. I want just to say that a master program in the United States is, people can graduate easily in a year and a half. The teaching methods in the United States, in Europe, are completely different than the teaching methods here. And we want them to learn the best. So we will have to come with some methods of how to teach. It's probably a hybrid between the local system, the new system that they are learning in the foreign universities. And then they can interact, if needed, develop the programs, the courses, the syllabi with the faculty at the university where they learn, and they can also collaborate, if needed, with the faculty to conduct research. Next. And they will teach, as I said, 8 short classes. Clearly this number is not cast in stone. They will teach also 4 credit classes in pharmaceutical department, and they will lead teams and doing research here in their country. Next. So what are the benefits? Before we speak about the cost, they will run the healthcare systems in a more efficient way. And remember, this is really what we are saying. We want to get more in a more complex situations with less money. They will develop processes and actions that are based in knowledge in their local environment. Introduce better processes to capture data, to analyze the data, They will evaluate policies, and that's very important. They evaluate policies based on data. And I believe that using the data, it can reduce corruption, especially leakage, and fake drugs. Next. Okay, there is a cost. How much will it cost? So train a master in the United States plus living cost is around $100,000. That's a lot of money. So I heard already some noise, oh, that's a lot of money. It is a lot of money. But, as I said, you shouldn't worry. The person that should worry is me. It's people like me that are saying, let me go and raise this money and I'll speak about it. Give me just a second. But it's 100K. So assume for a minute, I'm doing the calculation for 10 people that will come. We need more than 10 people. But 10 people, it's $1 million that you need to get from somewhere for 10 people. That's a lot of money. It's $1 million that you need for 10 people. But remember, these people, out of 10, I'm not that naive, maybe that only 5 will come back. So let's assume that 5 will come back and 5 will not come back. So I'm spending $1 million to get 5 people back in the country. I'm starting with 10, 5 will leave, 5 will come back. Each of them will teach every year 400 students. Why 400 students? Remember, 8 short classes, each of them 50 students, 400 students. 5 faculty, not 10, will teach 2,000 students every year. So 2,000 students, that's quite a lot. Now, let's think about comparing it to what is happening now. Suppose we want to teach 400 people, 2 weeks, what is the cost that we are paying now? So a very conservative estimate of the cost for 2 weeks course is $2,000. $2,000 multiplied by 2,000 students that this 5 faculty will teach is $4 million. Somebody is spending every year to train 2,000 people, $4 million. Looks to me like a fantastic deal. You spend one time $1 million, and in return you get $4 million every year. That's a good deal. That's doing more with less money. Now, you can say, Professor Basok, you underestimate the cost. Perhaps I underestimate the cost, and my analysis is really an initial analysis. I think that it gives us a very good idea about the cost. Maybe it's not $4 million every year, it's only $2 million that we are saving. And maybe these people we need to look, they will teach these classes 5 years and then they will disappear. 5 years, $2 million, $10 million, one-time investment of $1 million, not a bad deal. Can we actually afford to not do it? I think we cannot afford not doing it. Perhaps there are other methods to generate these people, and there are. I personally tend to believe, and that's my bias, that this is the most efficient way, the most sustainable way to develop this infrastructure. Next slide. So, can it be done? So let me tell you, we started doing it at my university, at University of Southern California. This year, on a trial basis, we will have 2 students. One of them is from Nigeria. They get full tuition, full living expenses, everything. They have to pay $10,000, that's all. So we have to raise the $90,000. And that's it. Now, can we raise the money? So once I decided that we want to proceed, and there was a lot of development in the process, what will we teach? What is the curriculum that we will teach? And I can go into the details later, but I want to finish. I went to the development group at USC. The development group at USC is the professional people that raise money. They are going to donors, and I gave them a similar presentation of what we want to do, and we developed some promotional materials. And when I spoke to the development people, they said, this is great. This is really a good cause. We should be able to get you money. And the week after, they found a donor that is willing to donate $300,000 every year. So we have already $300,000. We will start with 2. We want to try. We want to experiment. What I'm saying is it's possible. It's possible to raise the money. And I'm here also. I want to speak with the government. I want the government to participate in it. So I'll speak with people in the government. I want to meet potential donors. Perhaps a donor can give us the money and have Joe Smith Scholar and after his name or things like this. So, but I do believe that it is possible to raise this money. Now, just think about, suppose we have a consortium of 5 universities in the United States. Not everything has to be done in my university. And each university raises only $1 million. So each university can train 10 people. So we can train 50 people. And with 50 people, only 25 will come back. But with 25 people, we can train the entire population of managers, the 40,000 people, in 4 years. That's not a long-term solution. That's relatively short-term, or at the most, mid-level solution. We can train all of them. Clearly, this is 40,000 is for Nigeria. If we look at the entire population of managers in Africa, we are speaking about 300,000. So we need more than that to do everything in 4 years. But I think it's a start. It's a start that if this experiment is successful, will give us a completely different supply chain, because the people that will manage the system will be more knowledgeable. They will be trained by local people. It will be their own sustainable system. And you know what I hope? People are asking me, so Professor Basok, what do you hope? So I'm also a short-term and mid-term person. I hope that still in my life, and I'm an old person, people will tell me, Professor Basok, you are a nice person. You are always welcome to come and visit us in Nigeria. But you know what? We don't need you. We are now self-sustained. Next. So that's basically about human resources. I wanted to speak a little bit about information, but can you go to the last slide? I'll stop here. No, just the previous one, the one with next. Next. Now you're going backward. Okay, next. Just this was. So what I want to say is we need to just do it. We can analyze it, and I think that the return of our investment is fantastic. We can do it. It's profitable to do it. We need to do it because this is one of a set of solutions that will create a good health delivery system and that will be sustainable, a system that runs by the country, that it's independent, and is not long-term. It's relatively short-term, and it can be done. It's a lot of work. Thank you.
Thank you very much, Professor Basok Yehuda from the University of Southern California. Wonderful presentation. For now, I think in unison we can say, Professor Basok, you're a nice man, and we need you. We need you. Thank you very much. To moderate through this presentation is the National Coordinator of the Nigerian Supply Chain Integration Project. Can we please put our hands together for him?
Good morning, colleagues. Good morning also, professors. We have many of them in this room. Yeah. When I grow up, I would like to join them as professors. So it's a good way to start the day with a presentation by the professor of professors. That is Professor Basok. We have come to the same understanding that resources are dwindling. Disease burden is still there. And so we need to be more efficient. The professor has used his crystal ball to peer into the future and is now letting us know the sustainable way to go about that. And that is by institutionalizing capacity building. It's not by piecemeal, ad hoc ways of providing capacity, but by building the capacity through the institutions. So that reminds me, I don't know whether Professor Basok knows how medical doctors are trained in Nigeria. How in the teaching hospitals, where you have the teaching hospitals and the medical institution is there. So you move from the ward to the classroom. So maybe it's something that looks like that. But what interests me is that we are going to enjoy scholarship. And I will request that Nigeria takes 50% of the scholarships coming from Africa. So Prof has graciously agreed. So, okay. So we hope that we'll be part of the group, those that will get the scholarship, right? Okay, and we propagate it. So Nigeria has the capacity, Nigeria has the brain to do that. Prof, we agree with you, we do it. Prof, we can. Yes, we can. Okay, so thank you. Before we take some other presentations, I have two announcements. So one is that the Honorable Minister, we have gotten information that he will come and open and close the conference between 12 and 2. Today, Wednesday is our Federal Executive Council meeting. It is a meeting of all the ministers and other functionaries of Nigeria chaired by the president himself. So it holds today. So immediately the meeting is over, he will rush down here to open and close, as I said. So if any of our colleagues that need to be here, please, can you text or call? Tell them to be here between 12 and 2. And all those who want to have who want to see our action minister or have audience with him. The second announcement is that what we are doing in this conference is like a branch of a mega conference which is called Global Health Supply Chain Summit, which the professor has introduced briefly. Many of us were not here then. I have attended it twice. I've been to Senegal, I've been to Dar es Salaam. The next one is in November, going to hold in Ghana. So start saving some money or start looking for sponsorship to go to Ghana in November. So here we bring our own capacity, whatever we learn there, we are going to make presentation there. And many of you are going to make abstract presentations in Ghana in November. So start preparing for it. So those are, thank you very much.
Can we please put our hands together for our national coordinator? Please, we have a little Q&A session that will be coming after the tea break. In case you have questions for Professor Basok, do well to scribble down your questions. Let it be smart and specific and to the point. After the tea break, we'll take that. And like we said yesterday, today is a loaded package. We have 3 modules to take today, and this is just the first one. The next topic on Module 1 is actually the topic that will interest you. It's called Roadmap to Sustainability, Health Supply Chains Through Efficient Last Mile Delivery. Module 1, by the way, is Healthcare Supply Chains with Long-Term Sustainability. To take us through this journey is the Acting Chief of Party, Global Health Supply Chain, GHSC PSM. We call them Kemonis. Can we please put our hands together for Otto Kenny?
Good morning, everyone. It's good to be back again today. Just to clarify a little, it's not Chemonics, it's Global Health Supply Chain, a USAID funded project. Now, this is not a presentation as such, it's participatory. It's interactive, so I would like to divide us into like a session, like a breakout session once I finish the presentation, and we have some good discussion on what we think is the roadmap to a sustainable supply chain in Nigeria. So I have a little story to tell, and my story goes thus. I'd asked myself this question several times. How do you get medicine to patients when they arrive at the hospital? I asked myself this question over and over again. Going to a GP, general practitioner's office back in Ireland, and it started pricking me. So out of curiosity, I worked in St. James's Hospital in Ireland, one of the biggest hospitals, and in the materials management department. So I could see the flow of commodities coming to the hospital, into the wards. Then curiosity again, I looked at how do patients actually get the medicine. I moved to the pharmacy, working my way up the chain. Then at the pharmacy, I realized that doctor's prescription comes to the pharmacy and commodities go to the patient. That wasn't satisfactory to me. I wanted to know where medicines come from, who brings it to the hospital. Then I went to the private sector, worked in an wholesale pharmaceutical, one of the biggest in Ireland, and I could see the difference on how products get from A to Z. So in your next slide, looking at the public health supply chain in Ireland, just quickly, and this would help inform our discussion. So it goes this: commodities come from manufacturers, ends up at pharmaceutical wholesale in Ireland. The two biggest pharmaceutical wholesalers in Ireland, Uniphar Group and United Drugs. Uniphar Group happens to run a 730 million euro turnover. This is back in 2008 to 10, and United Drugs about €1 billion. This is a country where we had about 4 million population, and both combined, they're not the only wholesalers there, but two the biggest. Both combined would employ over 1,000 people. Both combined have over 1.2 billion in turnover. And both combined have regional distribution centers in Ireland to distribute commodities to, one, hospitals, two, retail pharmacies. And for that, they've introduced new mechanisms to distribute medicines to patients. From the regional DCs, they supply commodities to retail pharmacy, and there's over 4,000 retail pharmacies in Ireland. And within that, you can see there's a new delivery method that we all should be aware of. It's using the last mile as a model where commodities are shipped to your homes and to GP practices. Now, why am I telling this story? From manufacturers to retailers, it comes at a cost. Somebody pays for it. Next slide. To achieve a sustainable supply chain requires all these buckets. It requires an enabling environment. Now, if you go back to the first slide, the oversight there is the Health Services Department, HSC. All they do, they are the government body that monitors, evaluates, and regulates the supply chain, ensuring that commodities come with the right API and it meets the needs of the ordinary patient. Back to my slide. Next. So, To achieve this, we look at an enabling environment where the government is in the lead, where the government develops the policies, the government responsible for the governance of the entire system. It will require, the ingredient here requires private partnership, investments from the private sector, where infrastructures are put in place. By the way, I didn't tell you this. In Ireland, Uniphar alone have over 50,000 square feet of warehousing. 50,000 for a population of 4 million, not to combine it with that of the United Drugs. So, hence, this supply chain is managed by the private sector, essentially. The architecture has to be in the form that, one, the system design is robust enough. The system design looks from end to end, from manufacturers to the last mile. The technology behind it, a system that cuts across all the supply chain areas: procurement, manufacturing, and distribution. Next. So, this is the structure within our supply chain in Nigeria. Products are manufactured, they're shipped, be it by from a container to airplanes. It gets to the health facilities, but this comes at a cost. Next. Who is responsible for the cost in the supply chain? All this, from manufacturing, it comes at a cost. Shipping comes at a cost. Last mile distribution comes at a cost. In Ireland, the government supports people without jobs to get their medicines. Their health insurance in place for people that work. Individuals pay for their medicines if you can afford it. Hence, you have a system that is closed. It can sustain itself without much dependence on external forces. Next, please. In our distribution model, currently, you would see this is going to spoil the conversation we're going to have in the next few minutes. I don't need to go through this. I'm saying here, the question is to define a sustainable supply chain system. We're using state warehouses, and I know we have the Ministry of Health, State Ministry of Health here. Have the correct APIs when people receive it. So my question here is this: do we eliminate the state warehouses? It's a question for debate. We're going to the end-skip model very soon. Next. This is where we're going to in the next couple of years, where commodities leave our axial warehouses to the last mile. There's potential benefits for cost savings. ensure integrity of commodities. You can calculate or have visibility of your stock, and warehouse management is optimal. Next. So this is Kenny's sustainable supply chain construct, where the government is in the lead, managing all the activities across the supply chain, where we can have one system that you visualize what happens end to end in the supply chain. It is administered at a level where everyone is comfortable. The government is making sure that commodities that arrive this country have the right content, and what's the efficacy of medicines when it gets to patient. This is ensured. Next slide. Now, for the next 10 minutes or so, I would like us to break into 3 groups. And these 3 groups would look at 3 questions. Number 1, who pays for the supply chain costs? Who pays for the supply chain costs? Number 2, the group 2 would look at efficiency of a system does not determine the effectiveness of medicine. So let's improve the system end to end. Without medicines getting to the patient with the right content, we are wasting our time. I want this to spur some discussions. And thirdly, how do we get to a sustainable healthcare delivery in Nigeria? Who's going to help us here? Can we have the 3? Well, it's easy this way. Group 1, to my right. From here, let's have a cutoff point at the next table. So here down to the very last table. Then the cutoff point to be on table 3. Group 1. Raise your hands if you understand what I'm saying. Group 1 to the 3rd. Yes, from table 1 to my right to the middle table, table 3. Yes. Then from table 4 to, we're going to have a very short table for the last group. From table 4 down to the 3rd where Prof is standing would be group 2. Then from here, this way, would be group 3. Understood? Group 1, by show of hand. So we're going to work on who pays for the cost of supply chain. It doesn't come free. How do we see it working? Group 2, from yes, you're going to look at efficiency of a system does not determine the effectiveness of medicines. Yes? So we pick a... Yes, however we want to do it. So let's find a group leader from each table. So that group leader combines the conversation within that group and have a discussion around it. Group 2, Then the third group, I think this is for the professors. How do we get to a sustainable healthcare delivery in Nigeria? We have 5 minutes. So we have less than 5 minutes to have a quick conversation on this. So I'll suggest that one person would have 1 minute presentation from the group. at the time. So, thank you very much. I think the discussion is good. Can I request for? We have 1 minute left. So let's pick a speaker from the group to discuss outcomes. We have 1 minute, less than a minute.
Can siloed groups come to a consensus?
Group 1, are you ready? We're running out of time. I didn't realize I thought it was like 5 minutes. If we can combine with the same group with the other group, so it would help. Yeah, so let's round up. Time is fast spent, and I need one person. Can I get your attention, please? Yeah. So, can I get your attention? Can I get your attention, please? Hello? Hello? Time up. Round up, please. I need someone from group 1 to have 2 bullet points to just speak to. Group 1. No. So group 1, who pays for the supply chain costs? Group 2, if you're ready. Group 2. Group 2. Group 3. Ready? Okay, I think we will close this session now and present the outcomes later. This is quite engaging. I like the character, but it's the time. I didn't realize it. Someone should have told me about 10 minutes.
Let me ask you now.
Yeah, we don't. Okay, group one. Have we reached a concession?
No, no, I'm just waiting for him.
Sorry.
I think that group.
Okay. So group two is ready. Group two. Okay.
She's going to answer us.
Okay. We can start with group two.
Okay, let's go.
Group two.
We have two opposing.
We can hear your feedback.
I'm serious. We have two opposing.
Okay.
So, thank you very, very much. I'm really glad we had some very good interactive session. So, I'm going to hand the mic over to group two. Okay. Group one is ready. So, who pays for the costs in the supply chain? Can we pay attention, please? This session is over. We're just disseminating the outcomes. So group three, can we settle down? Can I have a representative from group three, please? Group three. Yes, thank you very much. Can we sit down? We have less than 1 minute. Can I get your attention, please? Thank you very much. I'm handing the mic over to group one to talk about who pays for the supply chain.
Morning, everyone. Okay, so based on our deliberations, we discovered that we are covered at certain points. So the first one is that currently the cost of supply chain is being borne by health insurance in Nigeria. So we have a health insurance system where partners, and then that premium is supported by a subsidy from the government. That captures usually the formal sector, but for the informal sector, there are other smaller groups that are funding insurance in their own way. We also, during our discussions, we mentioned that this system is partly, it's not sustainable in the long run, because when you have a system that is funded by external funders, there's a risk of them pulling out and then you losing that structure. So what we mentioned was that going forward, we'll have to develop partnerships with private sector to ensure that the fund is maintained. But overall, the cost of procurement, distribution, manufacturing is placed on the drugs, and is placed on the money that is put out as premium that people pay in the health insurance. Have I covered all our points? All right.
Do we have additional support?
Oh, okay, I think she has done well, but actually I think she started from the last.
Yes, what we said was now the status quo is who pays for the supply chain cost? Everybody. It's a shared cost. That's what we said. Then for sustainability, we feel PPP and health insurance is going to be the best way going forward. In summary, that is just what we agree in the group. Thank you.
Great. Thank you. Thank you. Group 2.
So group 2, the question is efficiency of a system does not determine the effectiveness of medicines, because the system we're talking about here is supply chain system. So my group is very interesting in that we have two different positions. One position is yes, it does. Another is no. So I'm going to speak for the yes, and it's going to speak for the no. Okay, so we actually looked at efficiency in terms of having the best outcome with the minimal resources. So the idea is that if the system is working as it ought to, based on best practice, then you probably would be saving some costs eventually. Like for instance, we looked at efficiency should start from the point of manufacturing up to the very last mile. So if you have been able to put systems in place that are working, you probably would save some costs in terms of, for instance, if you're looking at cold chain supply, and if you have vehicles that maintain the integrity of the commodity while they are being transported, you'll be saving costs on ineffective drugs eventually. So we looked at it in terms of that. So we said, yes, if you have an efficient system in terms of cost savings, in terms of human resource, you have personnel that are trained, you have enough personnel and all of that, and eventually it will tell on the effectiveness of the commodity. Remember, a staff that is not motivated will not even be able to maintain good inventory of the commodities, and it may impact on the effectiveness of the medicines eventually. So I'll hand over to my colleague.
Good morning. My name is Bolaji. So for the other part, I think there's a mix-up. The question says efficiency of a system does not determine the effectiveness of medicine. So we are saying yes, it doesn't necessarily, because what we actually looked at as we identified efficiency basically in this context as cost. So we are saying that the fact that you are doing something for cheaper or in a cheaper way does not necessarily mean you get the effectiveness compared to something much more costly. So we are saying we do not accept, like she said, the opposite of what she said. We are saying that this statement as it is yes. No, you're supposed to be no actually. Efficiency of the system does not determine the effectiveness of medicines. Yes, it doesn't. So what we are saying in essence is, if we are looking at cost component of efficiency, you can do something in a cheaper version, a cheaper way, but it does not necessarily mean that you are going to get effectiveness compared to higher costing.
Thank you very much. Group 2 are very controversial. So put them in a parking lot. And group 3. So do we have a consensus that it's a yes from group? They're still divided. You agree with them that it's a yes. So group 3. How can we get to a sustainable
good morning, everyone.
Supply chain?
I'm Francis by name, representing the group 3 members. For sustainability to be...
Sorry, can we pay attention quickly? Thank you.
For us to attain sustainability in the supply chain system or in the health sector, we came up with some vital points. One, we said before sustainability would happen, there needs to be an enabling environment. And under this enabling environment also have to bring in investment. What do we mean? We're talking about policies that need to be implemented. We're talking about policy implementation, political will, and the ability of the government to drive this system on its own. Talking also further on this, we talk about the national budget. The national budget needs to be spelled out in terms of the supply chain issues, in terms of what is going for commodities, what is going for the supply chain system, and what is going down the line again. Also, we talked about capacity development. Under capacity development, we made mention of growing the local market so that production could be done in country, and if this in country production is